Thank you very much, Ruti. Thank you very much, Emanuele. Thank you very much, Morton. I am very glad to receive this award. I am for sure also moved since John was a very good friend of mine, and he has been together with Henry Kaplan, the other great supporter of the International Conference on Malignant Lymphoma, ICML, from Lugano from the very beginning. We took a lot of advantages from his advices, and I am sure that he would be very proud today to be here and to see how ICML has become the major event in the field of lymphoid neoplasm. Well, my task today is to review the highlights of the last conference, June of this year. Of course, it is impossible in 20 minutes or so to summarize 4 days of keynote lectures, general sessions, focus on sessions, poster sessions, controversies, clinical case discussion, and so on and so on. In fact, like ASCO and ASH, we have started to organize the post-Lugano meetings worldwide. We had this year already one in Riyadh, in Seoul, in Tokyo, in Moscow, and I just arrived here from Beijing, since we had 2 in China, and a couple more will be organized in the next few weeks. But these post-Lugano meetings last 1 day and not 20 minutes. So today I have just to give you a minute glimpse of some of the data which were presented, and I decided to select those which were not as yet discussed based on the program that I had available about this conference. Now, every time we try to adapt or to update the structure of our meeting, and the last time the 2 novelties were, first of all, that the clinical case discussion, we had 9 sessions of clinical case discussion, including one for pediatric lymphomas, were dealt with by a kind of confrontation US against France. So we had 1 US expert discussing the case, all of them from the Mayo Clinic, and 1 from the LISA group in France, and that proved to be very efficacious, and we are already selecting the possible candidates for the same next time. And for the first time, we had a plenary session where the 3 abstracts with the highest score, we have always 8 experts evaluating the abstract, were presented. The first was presented by Dr. Rouillard from Marseille and dealt with the early steps in the transformation of follicular lymphoma. The second one, I will present it later on during my talk. And the third one was presented by Dr. Wisner from the NCI, who presented the provocative response data in 17p deleted CLL, since our Congress is also encompassing CLL and multiple myeloma. Now, this slide is, in my opinion, an interesting one. We received about 1,000 abstracts last time, and for the first time, the country number 1, as regards the number of abstracts sent to the organizing committee was the US. This for us is important, since we know that generally North American or many US scientists, they do not tend to send their best research to meetings outside the US, and this is, in our opinion, a demonstration of the success of the ICML. Now, another feature of ICML is that every time, the day before the opening, we have a closed workshop where 50 to 60 experts are asked to discuss in a closed workshop the hottest topic of the moment. And many of these workshops have led to important progresses in the field. I remember the one which led to the validation study of the real classification, the one who led to the first trials with antibiotics in gastric mold lymphomas and so on. But for the last 20 or so years, the hottest topic, which is with us still today, is how to subclassify diffuse large B-cell lymphoma. So we dealt with that already with our workshop in 1990 based on clinical factors, and that workshop led to the IPI. And in 1999, we dealt with the beginning molecular parameters, and this was just shortly before the publication of the first data about GCB and ABC. But still, we are, besides this tiny subgroup of double-hit lymphomas, we are unable today to clearly define other subsets. And so we asked the expert again to discuss that this year. And you see that at 4:45 p.m. of that day, June 18th, then Margaret Shipp, who was chairing the workshop, reported about the results. I am using 4 of her slides, and the report will summarize what we know or knew in June 2013 and what we still do not know and what we still have to do. What we mainly know is that the cell of origin distinctions are biologically and clinically relevant. We have a reasonable approximation of the mutational landscape in diffuse large B-cell lymphoma, but clinical assay will need to be robust, which up to now has not been often the case. We have seen some results today too, reproducible and applicable to paraffin-embedded tissue. And we know that MYC translocation are found in about 10% of the de novo diffuse large B-cell lymphoma with an inferior outcome, that half of those MYC translocated cases are double or triple hit lymphomas, and that 3 times as many cases express both protein, which are an independent predictor of survival, and are possibly enriched in the ABC subtype. Now, what we do not know, well, with the exception of TP53 and FOXO1, survival impact of any other recurrent mutation of diffuse large B-cell lymphoma is still not clear. And mainly we are unable today to evaluate the overlap or the exclusivity of most recurrent mutations. And what we need and what we lack for the time being is a systematic integration of copy number alterations, mutations, epigenetic data, and pathway perturbation. Now, the next steps, every time we try to have then something which comes out also from a practical point of view, we expect in the nearest future the written report, which will then be published. Different working groups have been formed, and they should deliver their results possibly within a few months. Now, in June of this year, we had also the almost final report of the workshop of 2 years ago, which was devoted on the topic lymphoma staging and restaging in the PET-CT era. Well, when we started this workshop, our hope was a little bit perhaps to be able to overcome the Ann Arbor classification and to have a new classification PET-based. We're dreaming perhaps to have a Lugano classification. Well, that dream didn't materialize. Sorry for the very busy slide, but this is the official slide which was presented in June by the group, so I thought I will use it. So, for the time being, there is a preference to maintain the Ann Arbor staging, this time legitimized by PET, although it was suggested no longer to use A and B, since they do not seem to have a lot of bearing today, and most of the physicians forget to mention that. PET-CT was accepted as the best staging for all PET-avid lymphomas, which are the vast majority of the lymphomas. And for the time being, the 5-point scale should be used until more quantitative measures are available and validated. So the whole story about SUV and so on, for the time being, is not considered to be validated or on an international basis. Bone marrow. At least for Hodgkin lymphoma, if the PET is negative, bone marrow biopsy is no longer requested. Possibly that will be the case also for diffuse large B-cell lymphoma, but we need still a few more data. Concerning the spleen, there are some problems in the evaluation, but if at the end you have still a residual lesion which is PET negative, this has to be considered as being negative. So what about PET in the follow-up period? For the time being, there are no data to suggest that PET should be used in the follow-up of any lymphoma subtype. Now, the next type, a lot of discussion have been carried out concerning the role of interim PET. The role of interim PET is somewhat established in Hodgkin lymphoma and in primary mediastinal B-cell lymphoma. It's still not very clear in the other subtypes, so work has still to be done there, and a new discussion has started. Some people, like Anas Younes, for instance, are proposing that we should forget about the bidimensional measurement and we should switch to the unidimensional measurement for evaluating response. The data are probably not yet mature, but while different papers have already been submitted concerning this workshop or are in the final stage of preparation, the one concerning the unidimensional versus bidimensional are still somewhat too mature. Now, let's come to some of the data. This was the third paper presented at the plenary where the paper were also discussed by a discussant. This is the ILGB study 90, which was presented by Emanuele Zucca, which is the biggest study ever conducted in multiple lymphoma with almost 500 patients who were randomized among 3 arms, chlorambucil only, rituximab only, or rituximab plus chlorambucil. You see here the response data. While the response rate for rituximab chlorambucil is statistically superior to the single agent, chlorambucil or rituximab, is there is a slight tendency of rituximab being inferior to chlorambucil, but this difference is not statistically significant. Looking at the event-free survival, which was the primary goal of the trial, you see that the event-free survival for the combination of rituximab plus chlorambucil was clearly superior to the 2 other arms, and this is the first trial showing that combining rituximab plus chemo is superior to the historical single agent. Now, similar data have been presented in Lugano also by a Spanish group with the combination rituximab plus bendamustine. And therefore, the next trial of ILSG will probably compare rituximab chlorambucil versus rituximab bendamustine. I will now concentrate mainly on some new data as regards diffuse large B-cell lymphomas, but before doing that, just a further piece of information concerning CLL. We had a presentation from unicentric study in a very important German comprehensive cancer center, where they compared in 2 similar populations one had a donor and the other one didn't have the donor, the outcome in very poor risk patients with CLL who were allotransplanted or not allotransplanted, and you see the important difference in favor of those who were allotransplanted. Similar data, which I am not showing in order to save time, were presented by Greenwald from Sydney as regards double-hit lymphomas, where two matched populations were compared, one with donor, the other without donor, and those who were transplanted from the very beginning, during the first treatment, with allotransplantation, double-hit lymphomas had an extremely superior overall survival as compared with those who were not transplanted. This was the first presentation of an eagerly awaited trial. It's an important trial with almost 700 patients, carried out under the leadership of Dr. Jäger from Vienna, and they were looking at the possible role of maintenance rituximab in diffuse large B-cell lymphomas. This afternoon, Emanuele Zucca will discuss the role of maintenance in different subtypes of lymphomas. As you see here, in diffuse large B-cell lymphoma, based on this data, there is no role for maintenance with rituximab. Somewhat surprising aspect at the last ICML was a certain revival of radiotherapy in the treatment of diffuse large B-cell lymphoma. These are US data from the NCCN centers, where, of course, this is not very easy to analyze, but there is a suggestion that patients who after R-CHOP radiotherapy of the bulky lesions did better. Similar data were presented by the German group. This is not a randomized trial. What they had in the Recover 60 trial, which has been presented many times in the past, patients who had bulky lesions, after R-CHOP they were irradiated, the bulky lesions. In the subsequent study, they used the same chemo, but they did not include in the trial the radiotherapy of the bulky lesion, and they had to stop the trial rather soon because on an historical comparison with the data that they had from the previous trial, they had a difference not only regarding PFS but also regarding overall survival. So again, it's not a randomized trial, it's a comparison between two subsequent trials. And the result seems to be due mainly to the effect of radiotherapy in patients with only PR after systemic therapy. The third piece of evidence here comes from Vancouver, where they have been using PET already since 2005, and if the patients remain PET positive after the end of the treatment with R-CHOP, radiotherapy is recommended if feasible. About 1/3 of the patients remained PET positive, but about 1/4 of those patients could not be irradiated, either because they had multiple sites or because of physician choice or because the biopsy was negative. So the point of that study is that if the patients who were PET positive at the end of R-CHOP could be irradiated because the lesions was amenable to a radiotherapy, the outcome at the end is the same as regards PFS and overall survival as compared to the patients who were PET negative. Now, the last aspect is related to which patients should be autotransplanted regarding the elderly. In many countries, probably a bit less in the US, physicians have been very scared about transplanting elderly patients above 60, 65, and for sure above 70, above 70. So these are Japanese data in patients either refractory or relapsing, having a refractory or relapsing diffuse large B-cell lymphoma who were transplanted. And you see three groups, 60 to 64, 65 to 69, and over 70. And the non-relapse mortality by age group is the same. Looking at the outcome, you see that while, of course, the outcome in the younger elderly patients is better, even above 70 years of age, after 2 years, the overall survival is almost 50%. So the take-home message here, be a bit more courageous in selecting those patients. Do not look just at the age, but at the biology of the patient. And a similar data was presented by the Canadian group. They have presented their trial GDP versus DAP already many times, and this time they presented just a breakdown concerning the age below or above 60 years. You see that in that trial, which proved that the two regimens were similarly active, the rate of patients who could be transplanted below or above the age of 60 was the same, and the same was also the outcome as regard the event-free survival and the overall survival. So to conclude, well, I tried just to give you a really a minute glimpse of some of the data which were presented. I hope that next time we will have the possibility not only to have very many people, but also very many of the people who are here today. Thank you very much to everybody.